welcome back. It was a very fast-paced lunch, but very good. And I'm going to start this session, as promised, with our student panel, with a reflection as a mother of teenage children. I am delighted to see that our panelists were so proactive that even without any maternal oversight, they assembled themselves and got themselves ready to go. And I'm just going to get out of their way and invite Mohammed, our moderator, to please come forward and introduce the panel.
Thank you and good afternoon. I think, this session, besides my very famous name, I think one of the reasons that I've been invited here to sort of moderate this session of great speakers is that I've also been fortunate at Emory to direct a student-driven program that is interdisciplinary in nature. And it's a short extracurricular event called the Global Health Case Competition, where we have interdisciplinary teams. You could almost think of it as a cross between The Apprentice and an episode of American Idol, where the contestants, instead of being sharp business people or excellent singers, are actually students who are medical students and public health students, business students, law students, theology students, who sit in a team together and deal with a problem, a case that we develop that challenges them over a course of a week. So that's one sort of student experience that for us has been an exceptional experience, and we hear a lot from our students that even that short time period is quite useful. I'd really like to thank the organizers here for thinking to ask students what they think, because that's this next session, is you're going to hear directly from students themselves, more in a clinical practice than a sort of global public health view, what they think of interdisciplinary or interprofessional health education. And we're very fortunate with the group we have here today. We're going to start with a global perspective here with Angela, who's all the way from Uganda. And Angela hopefully can hear us. Angela Sandra Namwese, she's currently pursuing a nursing degree at Makerere College in Kampala, Uganda. And she holds several leadership roles, both of the Medical Students Association, as well as the Students Professionalism and Ethics Club in Uganda. So Angela, take it away. You've got your first few minutes, and I'll introduce the next speakers after that.
Thank you very much for that introduction. My name is Namwase Angela Sandra. I'm a student at Makerere College of Health Sciences. I'm offering a bachelor's degree in nursing. What I'm mainly going to talk about is that my experiences in IPE. Next. Mainly at different programs in one setting. That is in lectures, tutorials, community education, and other aspects. Our perception of IPE is joining us together to learn together as one group, as a team. The experience we have in tutorials is that we get to put our ideas together, that is academically. And then when we get to the awards during clinical exposure from first year, we get to look at the patient in different aspects. We get to look at the patient in the angle of nursing, in the angle of medicine, in the angle of radiology. And we also look at the patient care generally, and also the economic and social factors of the patient. The best experience of IPE, I would say, is during COBAS. COBAS in full is community-based education, research, and research services. In this system, we are posted in different hospitals around the country. And in these hospitals, we get to rotate around different departments in the hospital. The main advantage of IPE is that it helps us to appreciate teamwork. It helps us to build the social aspect of us as we are being trained as health professionals. I could talk about the benefits of IPE in terms of what we have achieved. While in Cobas, we got to visit the pharmacy and also go to the wards. And during the awards, some of the biomedical engineering students came up with the best innovations in Africa. We were awarded as one of the best innovators in Africa. Why? Because we had a very good team. We had very good teamwork, and biomedical engineers had gotten to notice the challenges on the wards, and then they integrated them into what they had learned as biomedical engineers. And we came up with a solution to get to know someone's blood group in the fastest way than what we are using now. And the other advantage is that we've gotten to look at the challenges in the hospital, not only in health-wise, but also social-wise. While we were at the pediatric ward, we noticed that most ladies on those wards did not know much about family planning. And we came up with a project to sensitize the community about it, and were awarded for it by Make Every Woman Count. It's an organization in London that supports women in Africa. So basically, IPE helps us to look at medicine in a bigger perspective. It opens our minds to a better perspective. It helps us to learn together. It helps us to appreciate other professionals. It helps us to learn to work together as a team. Even when we get out of class, we get to work together during medical camps to get one team. The challenges of IPE is that when we join together as one team, the numbers become overwhelming, and sometimes they are challenging in practicals like radiology practicals, where we have to use one machine to learn. We can have over 50 students learning from one machine, and that's also in microbiology practicals and so on. Thank you very much.
Great, thank you very much, Angela. We're going to keep Angela on the line, just muted so that any of the background noise doesn't affect us. But we're going to hop right along. I know we have a tough act since we are the post-lunch act. But I'm going to introduce the students sort of in line. And we're going to next talk to Erin Abu-Raish, who's a nurse and has a background in community health, public and social policy, and interprofessional education. And she's currently also doing a PhD at the University of Washington at the School of Nursing there. So Erin, we'd love to hear from you.
So thank you very much for having me here with you today. It really is an honor to have been invited to join this meeting. We were asked to start the student panel with a brief 5-minute description of our personal experiences with interprofessional education. And there's going to be some images passing by to help you visualize what I'm talking about, but also to help you stay awake after lunch. So I'm a nurse now, but I'm a second-degree nurse. And during my first degree, I attended a small liberal arts school in the Pacific Northwest and was part of a learning community there where we weren't being trained to work together as teams, but where I learned many of the key critical thinking and team skills that I use to this day in healthcare. Our classes were small with engaged faculty and students from many different disciplines and involved lots of discussion and problem-based learning. There were frequent opportunities for social interaction with the expectation that as a member of the community, we both valued and had a diversity of interests from arts to sciences to literature and beyond. The liberal arts model was a great experience for me, and I was surprised when I chose to go to nursing school in the Northeast that problem-based models of education and interaction with students from other disciplines weren't a part of the experience that I had. In fact, the teaching style was quite boring, and what I've heard since referred to as death by PowerPoint. And I went from having been seriously considering going into social work, public health, nursing, or medicine, and having positive views of each of these professions, to being exposed to negative stereotypes, and at one point found myself sitting through a PowerPoint lecture titled How to Talk to Doctors. And in all fairness, in retrospect, I think that lecture was meant to teach SBAR format, but that isn't really what it accomplished. So, I came out of nursing school with good clinical knowledge and experience and a strong sense of my role as a patient advocate, with the empowering but ultimately negative takeaway message that one of our main jobs as nurses was to be the last best line of defense against other professions making mistakes. After finishing nursing school, I of course did get exposed to working with other disciplines as part of healthcare teams. Clinically, I worked on an inpatient solid organ transplant floor and later in home care with a team of visiting doctors, nurses, OT, and PT specialists, where I had the chance to develop team skills in practice, but I think they would have become even better if we had had formal team training. A few years after finishing nursing school, I entered graduate study in education, still in the Northeast, continuing to work full-time as a nurse to have the opportunity to think about how we could better educate nurses. While I had survived a PowerPoint-based nursing education, I wasn't interested in teaching in the same way. Early on in my master's degree was the first time I had heard the term interprofessional. An opportunity arose that allowed me to add nursing students into existing short-term dental service learning trips to a small community in Honduras. You'll see some images of that going by now. So over 2 years, we developed an oral health promotion project that incorporated expertise and participation from dentistry, nursing, a local arts nonprofit, and local school teachers. What I learned most from this experience was first, the importance of having a daily debrief to make sure that everyone is on the same page and to help contextualize the experience. And second, that social interactions outside of work time were important time for people to continue to learn about each other's roles and added a lot of value to the experience for both groups of faculty and students. In 2009, I came back to the West Coast to go to the University of Washington for my PhD because of the extensive opportunities for interdisciplinary research. I was lucky to have gotten connected to Brenda Zeeler prior to applying to the program and have been able to continue to pursue my interest in IPE as a research assistant on 5 different grants over the last 3.5 years. During that time, I've conducted an interprofessional lit review that was recently published in the Journal of Interprofessional Care, helped organize, assess, and evaluate IPE events for hundreds of students, been involved in faculty development activities, and I also started the IHI Open School chapter at the University of Washington, which now has over 75 active members from 6 health profession schools who have been involved in a national root cause case analysis competition, hosted speakers, and had pub quizzes and various things like that. We also co-wrote a Project Chance service learning grant with the Pharmacy Student Association. And from all of these experiences, I can summarize 5 key messages from my perspective as a student. First, small groups, problem-based learning, and interactive approaches to education draw people in and make things more memorable. Second, team debriefs are effective and need to be positively oriented and well facilitated. And they're usually better received than pre-work. Like for example, with the group that we had in Honduras, we had a pre-orientation that people weren't terribly engaged in, but the daily debriefs afterwards were very well participated in and very meaningful for people. Third, early, often positive interactions are key for developing an IP culture, and that includes social interactions outside of class time. And that's been an important part of the IPE approach that the IHI Open School group has brought, and the things that are most well received that we do are usually the social events where people can actually get to know people by name on a personal level. And fourth, support for and facilitation of student involvement helps increase sustainability of student organizations and reduces barriers to participation. For example, with the Project Chance grant that we wrote, we spent the vast majority of the funding period trying to figure out how to work together and how to get to patients and get IRB approval before we ever really got to it. And that's the point that students want to get to, is to actually be able to work with patients together as a team. And finally, as we all know, IPE and IPP are growing, and the linkages need to be stronger. And faculty development is needed in both areas to expand the faculty who are IPE competent and to support innovative approaches to education.
Thank you, Erin. I can tell that everybody took it very seriously when I said stick to your 5 minutes, and I appreciate that. That'll give us more time for discussion. Dr. Thomas Lewis is a psychiatry resident, a first-year psychiatry resident from the Medical University of South Carolina, and he's going to tell us a little bit about his interprofessional education experiences at medical school and before.
Good afternoon, everybody. I wanted to start off by thanking Dr. Amy Blue from the Medical University. I know many people in this room know Dr. Blue, and I got to know her as a first-year medical student. That was quite an opportunity, and thank you to Patricia Cuff and Megan for helping to coordinate this and ask me to come and speak. So I thought what would be helpful for today would be just to kind of highlight a few things that were important to me as a medical student at the Medical University, and then talk about kind of, as I've transitioned to an intern this year, big transition that I took in July, how I've practically used that. And I want to also just take a moment to thank all of you in this room. I really believe in interprofessional education, and obviously today it's been refreshing to hear the hard work that the leaders of our profession are putting forward in IP education, because that's what we really need when we're new students. As a first-year medical student, it's overwhelming, and I didn't know what all I needed to focus on. I knew I had to do anatomy, physiology, the basic sciences, but to then have a course or a curriculum that included interprofessional education sends a clear message that it's something important that I need to learn. So I first got involved in interprofessional education through the Student Interprofessional Society. It's called SIPS at MUSC, and it's a part of the Creating Collaborative Care initiative that Dr. Blue set forth several years ago. And it's kind of like Erin was saying, more of the social aspect of interprofessionalism. So I became the vice president of that group, and what we did was try to get students from all the different schools across campus together for monthly meetings where we would highlight examples of good teamwork going on at the Medical University. We also did community service projects together and essentially hung out. So it was a chance for us to get to know each other as students and talk about our different programs and the strengths and weaknesses and the different challenges that we were all facing. The other thing that I did really that I think was helpful for me as a learner was I participated in the pilot IP course that we did at MUSC. It is now a required course on campus, and I definitely believe that that's a positive impact, as I said before, making it a part of the curriculum. But in that class, I did a root cause analysis with an interprofessional group of students where we looked at a patient's case and kind of discussed between the different professions what went wrong with the case, what could have been done differently, and where communication broke down in the groups. That was very helpful for me. I think in all of those experiences, it was really creating the space for being interprofessional and learning together and really exploring what each profession brings to the table. So where that translates into a new example as an intern is in September, I was on an inpatient medicine ward. And you're young as an intern, learning how to take care of covering patients in the middle of the night, and you would get pages. And I can't tell you how thankful I was when I got a page at 2:30 in the morning from a nurse concerned about a patient, and I would go into the room with the nurse, and I would bring the nurse in with me, and we would look at the patient together, and I would ask the nurse what was the concern, and we would look at it together. And it was really helpful, and I respected that nurse's knowledge because I knew that they had probably a lot more clinical experience than I had at that time, but we worked together. Or if I needed respiratory therapy to show me how to do the right orders for the settings, or get physical therapy to help me with the assessment for a patient going to skilled care nursing facility. So those are examples where I look back on how interprofessional education shaped my thinking now, and I say, it really helped me understand where the other profession came into play, how we can work together, and at the end of the day, the common theme is patient care. It really boils down to providing good patient care and understanding our own professions to do that together. So I can't emphasize strongly enough what it's meant to me to be a part of this movement. Thank you all for everything, and I look forward to seeing where this is going. So.
Thank you to Thomas. So our final speaker is Jenny Wong. She's a third-year pharmacy student from the University of Minnesota, and she's also the chair of Clarion, which I believe is a clinical case competition. And she was going to tell us a little bit more about that.
First off, can anyone see me? Just so when Patricia first asked us to go through a teleconference call, she asked us to sort of go through our perspectives of what it's like to go through an IPE curriculum. So I thought I would start off with a timeline of my career starting as a first-year student to a third-year student. So during my first year, the University of Minnesota, which I'll call the U at this point, had a required course called the FIPSI. It's a Foundation of Interprofessional Communication Collaboration. So it was many groups of students of different professions coming together to talk through different cases that we had, and that was the only required course that we had to do. Then, as I went through the course of my first year, I decided to join Clarion, which is something similar to what Aaron and Thomas had as well, where what happens is you're given a case study, and that case study gives you the macro level of how a patient goes through different multiple healthcare systems, and it's not just siloed to clinical work. It actually involves MHA, public health, social work. And then I went into volunteering for the Phillips Neighborhood Clinic, which is a student-run clinic. And that one actually allowed more of the clinical value of applying my knowledge to it. So moving on to the second year, Clarion was an elective, PNC was elective, FIPSI was the only required course. Moving on to my second year, I decided that I would take a diabetes course, which would help us work with nursing students on how to deliver diabetes education to different patients. And one of the goals was to come up with a communication plan between the two disciplines, so that way we would work together. Now, if you think about it, there's only pharmacy and then there's only nursing. There's other disciplines that were missing in this education. I continued to do Clarion, I continued the PNC, and then over the summer, I was allowed to rotate with different clinicians at a teaching hospital. And that was my first introduction to actually what rounds were in an acute care hospital. I was able to actually work together with different medical students, interns, residents, nursing, and as well as pharmacists. And that was my first taste of what actual interprofessionalism was. And that was towards the end of my second year in pharmacy school. So as you can see, there's some sort of delay in terms of interprofessionalism. Moving into my third year, my current year, I've been taking a immunization delivery course. And once again, this is only with nursing. There are other disciplines that were missing out of this, and what we did was we did a simulation center, much like the University of Colorado, where we have patients coming in, and they just had the flu shot, and they pretend that they experienced an adverse event. So then this actually forces us to live knowledge in action. You actually work together with the nursing students to try to figure out who is doing what role and actually how to help this patient. Now, as I go through this, I have to say that the electives helped me learn about what interprofessionalism was, and my rotation and my experience at the PNC really helped me apply knowledge to practice. As far as challenges goes, if you think about it, what is missing? We are missing PT, we're missing dental, we're missing public health, we're missing medicine. And all the electives I've taken is very much just pharmacy and nursing working together, which I find to be a little bit limiting. There's a sort of disconnect where interprofessionalism was required in my first year, but then throughout the 3 years I've been there, it's not been a requirement anymore. So the message that was given to me was that I just had to get this course done and over with, and IPE was just a check off for most students because it's not required in my 3 years. The third part I learned is that in the rotations I've had, there's a difference between actual collaboration and a team made of multiple different disciplines. I can have a team made of medicine, nutrition, nursing, but if they don't talk to each other, then that's not IPE. That's just different Skittles mix of interprofessionals. And thirdly, there's a lack of actual practice. Like I said, it wasn't until my third year that we actually had a simulation where nursing and pharmacy students were working together that's not paper-based. And so I find that we should actually have had that maybe in the first year. And that's sort of where I'm going with improvements. The U have done a lot of improvements now. Dr. Brand has been involving a lot of the Clarion members as part of the IPE development curriculum. The College of Pharmacy is actually building a new curriculum where interprofessionalism is a required domain that we must all fulfill, not just in the first year, but throughout all 4 years that we're there. The PNC, while it's great, one of the limitations of the clinic was that it was also applications-based, as in you had to apply to be part of that clinic, And it's almost unfortunate because there's only so much that a clinic can have capacity of students for. So then if they can't take other students that really want to do IPE, those students are left out. And so the PNC has actually created an elective course specifically just for those students that want to learn about IPE. And lastly, the FIPSI course, despite the fact that it was only required in our first course, has been a sustainable program that we've had since my first year up until now. It's in the 3rd year running, and it's planning to continue as well. Why is IPE actually important to me? It's because it's my belief as a clinician that IPE and healthcare delivery cannot be done in silos. Patients have to see multiple different healthcare professionals, and they will be talking to different people, but it's not effective for a patient to go to multiple different appointments. It's better if they're actually there and they can see everyone at the same time. And one of my experiences, and I'll bring that back to the clinic, is that I had one patient who had triple comorbidities. He had hypertension, he had diabetes, and he had cholesterol. And as his primary clinical pharmacist, I brought in different disciplinaries because I just thought that even though I may be good at I may know what they're doing, they might be doing the job better than I could. And so I decided to proactively go out and collaborate with them. Because in my mind, IPE is translated as a collaboration of care. If you look at just IPE by itself, interprofession, it's almost as though we're highlighting the divide that we have as professions, and really should be focused more on the patient and the collaboration of care model that we are actually delivering in action. And so I actually thank the U for providing me with this opportunity to come and speak. But at the same time, I also thank the U for giving me the perspective of what IPE is. Because before I started pharmacy school, IPE wasn't really a term that existed in my mind. I'll be honest, I didn't know what it was. I didn't know what defined it. But it was actually through my academic experience and working with patients that I actually was able to really appreciate it and really see how this interdisciplinary system helped my patient, because now he's actually completely controlled in all three disease states, and he had a continuation of care with every single one of those professions that actually came to help him. So I thank you all for listening, and I look forward to your questions. Thank you.
So I think you can see that these were excellent speakers and gave us a really good perspective on what it's like for students themselves. And we had a nice mix of nursing, medicine, and pharmacy represented here on the panel. The other comment I'll quickly make before I open it up for questions is that it seems to me, from what I'm hearing, that it's not just the folks in this room and the folks that lead healthcare organizations that are thinking about the next generation of education. It's not just the supply side, it's actually the demand side. It's the students themselves that might actually propel us to do more in this area of interprofessional education, because it seems that besides youthfulness, they're actually bringing demand and saying that we actually want to work together and we want to build better teams for better care. So I'm happy to open it out for questions at this point. Yes?
Thanks, Lucinda Main. We hear, not infrequently, that not every learner is as enthusiastic as the five of you are, and might reflect that I just really don't know what I need to do this for. And can you think back to your pre-health professions experience and think of how those who are preparing pre-health profession students could work with our schools to change that acculturation?
Yes.
I'd like to say that with that, ultimately you have to think about why you decide to go into a healthcare profession. It's really for the patient. At the very end of the day, having a collaborative care model will help improve the patient outcome. If you're just a nursing student seeing one patient, you probably would like to have the expertise of somebody else and bring that in. So why not build that thinking of actually reaching out to other professions to actually work together and come up with a plan to treat that patient appropriately and as effectively as you need to. And with pre-health professions, I think we need to keep telling them that it's not just a matter of you getting into school, because I'm sure that's their primary concern, is to be able to actually get into the school that they want to, but to drive the fact that it's really patient-centered care. You really want to do as much as you can to help the patient.
I think one of the things that we've been finding with the work we've been doing at the UW is that creating situations that students want to be in, and having IPE be part of it, but not necessarily be an overt, you are coming to an IPE training or you are entering an IPE area. So we've done a lot with simulation that students want to be in these areas, and that's not necessarily the pre-health, but places that students see what the value is that they're getting out of it, but then they're also adding in this IPE component that they don't necessarily see until they get to a debrief or something like that.
Other questions? Yes.
Well, first of all, again, thanks to the panel. I think it was really refreshing to hear the perspectives of the students. And Ed, you pointed out that I think we're all committed to IPE, and I think everybody in this room has drunk the Kool-Aid. So it was refreshing to hear some positive experiences that you've had in terms of that. But I really would like to hear your perceptions about what are the barriers in your institutions for catalyzing more IP and really getting it into the sort of the mainstream of your institutional's thinking and educational programs and ultimate mission in terms of practice. Because I think as a workshop, we're really trying to figure out what the committed among us can do to accelerate and facilitate and catalyze. So I'd be very interested in how you to talk to Aaron about faculty development as being a limiting thing, and Jenny, you mentioned the fact there was only one other discipline that you were engaged in, so that was limiting in that sense. So I'd be interested in knowing what other barriers in terms of leadership or other institutional obstacles there are to fully implementing IPE.
Well, I'll speak briefly on a couple of things. I think primarily, speaking more from an MUSC, the Medical University perspective, our president, Dr. Ray Greenberg, is a big proponent of IP education, and actually had the opportunity while I was in my second year of medical school to sit on the strategic planning committee for interprofessionalism that Dr. Greenberg set forth in his overall strategic plan for the whole institution. So I think that sent a message from the top down that the key leaders of the institution were interested in interprofessional development and education. So I think that's certainly an advantage. One of the things that Jenny mentioned, and I completely agree with her, the IP course that I did as a pilot as a medical student was something that I proactively sought out and did. It was not a requirement. It is now a requirement, and I think that's a good start. You know, I think there's a big debate about what should and should not be required for different disciplines as they go through training, but it kind of goes back to what I said. We don't question taking things like pharmacology or anatomy or the basic courses that we need to get our professional training, and yet we are questioning this. And so I think the question is why, and it's because it's maybe a newer concept or newer theory that we're discussing, but it's really not new. It's just a new way of kind of reframing what we need to be doing and focusing on it. So I think that's one thing to kind of think about in terms of planning. That would be my key thought on it.
Can I ask Angela also if you have an opinion about that regarding the question which was about barriers in your institution? Did you have any comments about that? Is she able to hear us? Oh. Can you just check that your microphone is not muted? There we go. We can hear you now.
Can you get me now?
Yep.
Please come again with your question.
So the question was, what barriers do you face in instituting and implementing interprofessional health education within your institution?
Well, the main challenge is that when we are joined together, we become a very big group. So when it becomes a very big group, the services seem to be very inadequate, especially in practicals.
So on a day-to-day basis, you mean, in terms of delivering care?
Not in delivering care, but in learning. That is like learning how to operate a machine or something like that. The numbers seem to be overwhelming. That is the main problem. Otherwise, it can still be dealt with.
Thanks. Other questions? So I have a hand back there.
Yes, if you had one change, you could make a little different spin on the barrier. Focus on the solution. If you had one change that you could make at your institution that you think would have impact to bringing other students' insight around IPE to the forefront, what do you think that change could be?
I'm sorry, could you frame that a little bit differently? Are you thinking about how we can break the barrier and move IPE as a forefront issue, or how we should implement IPE as part of a curriculum?
So how you could bring IPE to the forefront among other students. What changes, what is the single change that you would recommend at your institution?
I'll talk about one thing. So every year at MUSC we have Interprofessional Day. It's a requirement that people go to. I keep using the word requirement. I do believe in having required activities to kind of send that message. But one of the things that the first year students participating in IP Day do is they break off into small groups in their interdisciplinary, interprofessional groups. And we go around the room and break up into professions, and we get a sheet of paper, and on that sheet of paper we write the training credentials to get to where we are today. So like, did we have to go to college? Did you have to have the different credentials, what it took to get in to the program? You talk about how long your training lasts, what your training options are, kind of specialization, residency, fellowship. And then the last part, and this is key, you talk about stereotypes of your profession and what you never want to hear someone say about you. And then after we spent time as a small group doing that, we went around the room and one person from each little break-off group spoke for the group and talked about that. And it was amazing to hear some of the stereotypes that people had either heard, believed, or what they didn't want said about them. And that was from physical therapy, from medicine, from nursing. That came in January of my first year of medical school, and at that time I was already kind of working with Dr. Blue and interested in interprofessional education. But I think that was really powerful for everyone in the room, and I wish that there was a way that kind of learning and sharing could happen early on for everyone going through their education, because I think that's really when you start to realize what it is that we need to be changing in interprofessionalism.
I have two things probably that I would change actually. On the more administrative side, I would align our calendars, because our academic calendars for our different schools are not the same. And that would better facilitate creating groups of students that could work together over time. And then from the student side, something that someone had suggested to me the other day that I think would be really valuable would be to create an interprofessional student leadership center that would have either a set of offices and resources that student groups could tap into to develop some of the more social activities and help students to set up these things. Because right now we have a number of interprofessional student groups, but we have to kind of beg, borrow, and steal resources from people to be able to host happy hours, to host things where people actually come together and interact.
Jenny, did you have any comments before I move on?
I'd like to piggyback off that idea, and that having a coordination of the schedules would be really good. One of the issues that I've experienced that the second year medical students go on rotations already, and the third year pharmacy students don't go until the third year. So you sort of have this disconnect where there's almost an extra level of education that we have to go across in order to even work together. And one of the solutions I really enjoy is Clarion, in that Clarion develops this case-based scenario for students, even if, regardless of your knowledge of health, your health knowledge of pharmacology, anatomy, it's a patient-based case, and it kind of gives you an idea of how these gaps of care and this lack of communication amongst the different disciplines have affected the patient, and how the patient goes through the story of the patient and why the patient went through what they did. And it gives you more of a face to why you are a healthcare profession in the first place. And I think once we're in the profession, we sort of lose sight of that, and we get a little bit selfish as students, where it's all about me and what can be done for me. And we really should be driving the message that what can we do for the patient? Because that is what our profession is primarily, basically as our first goal, is the patient.
Thanks. Angela, can we also get a comment from you? I don't know if you heard the question.
Thank you very much. One thing we would change with the IPE system is that we would integrate it with the upper years. Usually it's concentrated within the first and second year, then third year we get to pathways. Pharmacists go their way and medicine people go their own way. So we would change it and actually involve students on the wards together as one.
Okay, so it seems like there's a lot of processes in terms of how we organize education. Other questions? Yes, ma'am.
You've all talked about the importance of delivering patient-centered care together. My question is, how much have you heard from patients directly about what matters to them?
Have any of you?
I've mostly experienced from when I've been working as a nurse in clinical areas, and for example, when I was working as a visiting nurse and I could call the visiting doctors on their cell phones or the physical therapists, patients really liked it that they could, I would get a call from somebody who had gotten a call from a patient saying, I'm in pain, something's wrong. They would call me, I would go over, and we would all be essentially conferencing together on what was going to happen with that patient. And that was a very unique program, but it was something that patients really liked, and it helped them stay in their homes. And they were very aware and vocal about the fact that if they didn't have this easy access to their providers, they wouldn't be able to stay in their homes. They would have to go to the emergency room more often and probably would not be able to return home.
Angela, can I ask for a comment on this question from you in terms of what patients themselves relay back to you about the experience of team-based care and or team-based education?
Come again, please.
So the question was, have you actually heard from patients themselves on what their experiences of IPE might be like?
Not really, we haven't.
Okay. Well, let me open out to more questions. I know there are a lot of questions. I promised that lady, and then I promise I will turn this way. Go that way.
Yes. Anecdotally, from students, they've talked about something that's been interwoven in all of your sharing today, and that is the opportunity to have the longer-term social connections and relationships. Because what the literature has shown is that people that, those of us who might have grayer hair, see sometimes IPE as just this case specific and then move on to something else, and that the younger students are really looking for the longer term connection and relationship. And each of you have talked about that social element, and I'm wondering, separate from the formal education, if you would just talk about the importance of that and how it is that we might think about structuring things differently to facilitate that.
I guess I could address that. In terms of just social connections, I think one of the results of the social connection is the build of trust. And part of teamwork and part of collaboration is this trust that we have with different professions. I have personal relationships with multiple different medical students and nursing students, and if we didn't have that relationship in the beginning, I don't think they would trust me as much when they have drug questions. And so having that social aspect does build an additional value of trust between the disciplinaries, and also lets you understand the behaviors between different professions, because we all act differently. I mean, even though we go through the stereotype exercise, I think that gives you an idea of what you think a healthcare medical student is like, what a nursing student is like, what a pharmacy student is like. But it gives you value in that you can adapt to that and adapt to the way they would work so that you can be more effective together. And having that trust would actually build that. And to piggyback off Madeline's question about patient care, I have two scenarios. One was acute care, where the patient really liked having multiple teams of people there, like a team of 10 people there to understand every single aspect of their situation. But in a primary care clinic like the PNC, having 10 people in the same room with them is overwhelming. And so at that point, you have to decide whether or not what specific core team you want to have in that room, and then build around that, so that way there's at least a transition of care from when they're done with the PNC, and then the rest of the actual beyond core team can reach out to them as well. And so they do appreciate interprofessional teams. It's just maybe the size might be slightly overwhelming depending on the situation.
I think one of the things that I've seen in the evaluations that we've gotten back from students from the, not necessarily the social events that we've had, but some of the more simulation events, is that it really helps to break down historical hierarchies between professions. And so one of the most resonating feedback things that I've ever seen was a pharmacy student who at the end of his training said, I learned today that I don't need to be afraid of doctors. And that seems like something that everybody in this room knows, that nobody needs to be afraid of another profession, but it's something that when you've actually talked to somebody, had an interaction with them, know their name, know that they're a nice person, it's really hard to have negative stereotypes about an entire profession if you have seen a number of examples of people who don't meet those stereotypes. And I think that when you're having, if you're in a class together, that doesn't necessarily come through. It really takes getting to know somebody a little bit, having those social interactions to build those lasting impressions.
Okay.
We build those social. How could we build those social opportunities in, maybe?
Well, I think that, you know, speaking from the SIPS perspective back at MUSC, those were optional things. They were not required for students to do, but we had fairly good turnout. For us, we were able to offer lunch to 50 people, and we held it during a lunch hour. That was kind of, we talk about a coordination of academic schedules, and that is a whole nother conference. But I think that in terms of the lunch hour, we were able to get a lot of different groups interested to come and hear what was going on, and so they would attend. So.
If I can add to that, and this is from my experiences of going to medical school in South Africa 15 years ago, in first year, you're required to take one course on public health with medical students, nursing students, physical therapy students, and OT students on public health. And the requirement of being in the class and on being interdisciplinary, on working in interdisciplinary teams forced you to get to know folks from different disciplines and backgrounds and what they were training in, and it broke the barriers down very quickly. There was, you know, getting to know the medical students and nursing students right from day one. So more questions. Yes, ma'am.
So I thank you for the powerful stories that you've told, and would like to draw an analogy to a project that came out of Dartmouth not very long ago. It was a publication where a group of medical students really got together and put out, I think, a wonderful manuscript, very thought-provoking, that was addressed to peers, to say to other medical students, and this was around quality improvement, you know, we really believe strongly that in order for you to practice the best care possible, you need to train in a place that practices quality of care and is transparent about it. And so you should really look beyond the name of the place and, you know, sort of the stature or the recognition of the place, and really think about what's important to you. And we're suggesting quality ought to be important to you. I just wonder if you would consider a similar publication to students that are looking at health professions education at the college level. There's a group of health advisors that could probably, at that level that would mentor students, and I wonder if you could reach college students through this group of health advisors to say, look, we've lived this and we think this is really important. Please consider this as you're looking at your health profession school. Pick the ones, that focus on this, the whole demand issue that you've raised.
I think that's a great comment. Actually, from the perspective of the business world, there have been a number of publications about the millennial generation of workers in the corporate world, and I think it's high time there was something in health and health education of young health professionals. What does the 21st century health professional team look like? Your question.
Thank you.
Welcome.
So I'm beginning to have a concern, and I want to run this by you. First, you're fantastic. This is a really great panel. Thank you so much. There is a discussion of IPE as if it's a separate thing. It reminds me when we introduced research or theory courses. So they stood in their own, and you said that, Jenny. So IPE was a course that I just finish it and I get rid of it. But really, IPE could be just, it's not a separate thing or a separate room or a separate entity, but rather it would be integrated in courses. So for example, teaching a nutrition course that has students from all fields, teaching a public health course that everybody takes, that would be required. That, in my mind, is one side of IPE that we really do want to implement. And I'm actually asking this as a question rather than saying, oh, I have an IPE experience, I have an IPE room, I have an IPE group, and another group. It's IPE would be integrated, anatomy and physiology would be taken together, nutrition, ethics. So I want to hear your reactions to just these two ways of thinking about IPE.
I would agree that that's how it should be. I think part of why I shared my story of having how when I entered nursing education wasn't how I expected it to be is that I had assumed that that was what happened in healthcare education, and I was very surprised and disappointed that that was not the case. And I would be very supportive, and I do think that's where we should be going. Is it shouldn't be something separate. It should be part of the education of healthcare students.
Yeah, I would just say that actually thinking back on medical school, I worked with Dr. Blue for my first and second year of medical school, hit the wards as a third year, and it was striking to me that I saw a lot of interprofessional activities going on that weren't specifically dubbed interprofessional or weren't required activities. Specifically psychiatry, which I've chosen to do, is inherently interprofessional. We have the community health model with the psychiatrist, psychologist, social worker working together. So I think that what we really need to do, and especially from a logistics standpoint, is tap into that and help to normalize it, because really when it just becomes a part of what you're already doing, it doesn't seem like less of a barrier. So, certainly we're calling things interprofessional classes, activities, things that we're doing, but when you look at it, when you're doing them correctly, it's really just integrating what's already going on and kind of focusing on the positive aspects and the team aspects of what's going on already.
I think one of my own issues is that if there's such a highlight that IPE is in of itself separate, that it should really be cruise control as part of your physical anatomy, your typical education, and to actually take it out from the curriculum and focus and highlight on it is a good thing, but also I think a bad thing, because we're almost highlighting that it's an issue. And so with students, I feel that if you didn't highlight it at all and you just condition them to just think about it naturally and not think about it and twist it and spin it any way you want, that they don't even think of it as an option, like Thomas has said, that might actually be more effective. In addition, I have to say, at the U, medical students and dental students take courses together. Nursing is separate and then pharmacy is separate, but we all take the same courses, which I find kind of ironic. And I thought that it almost is at first year you're siloing every single one. So why not just start our first year all together, and then if we have to split off and focus on a particular expertise, then we could do that instead. And then you wouldn't have this pull out of IPE on the side.
So Angela, did you want to comment?
What I wanted to say is that we actually get what the lady was saying, and it's actually done at McCray College of Health Sciences. We actually cover, the first question, it is ethics and professionalism, and we cover it together as one. And we cover this in tutorials, where each tutorial has a radiology student, a nursing student, a pharmacy student, and a medicine student. We also carry on for the first 2 years together, so we cover the physiology and the pathology and microbiology together. And even after graduation, the teams still work together. They still appreciate the teamwork that they built during school.
Fantastic.
Thank you.
Thank you. So we probably have time for 2 more questions. I saw a hand there from the gentleman.
This will be well, maybe quick, I don't know. I had 2 questions. One, Afaf has already asked, and I think you've wonderfully addressed. You've wonderfully addressed many issues. I wonder if you would be willing to venture with me into more dangerous territory. When we get together, often the issue of suitability of students, not so much for interprofessional education, but for some of the correlates, commitments to social goods and so on, come up the whole time. That is, what is the suitability of people for the health professions training? So my question for you is, as you reflect on your own experience and look at your colleagues, do you find much non-suitability for health professions training? Or do most of the students, there will always be, I guess, a few exceptions, but do most of them, in your mind, seem suitable, so that the problem is really how we then deal with them during training, as opposed to the entry into training problem?
Just as a clarification, can I ask, in terms of suitability, are you talking about the ability to deal with the academic rigor, or are you talking about the social aspects of?
The social aspects and being committed to an altruistic life to enhance health, teamwork, okay, or whatever other surrogates you might think of for that ultimate aim.
I do think that it would enhance the effectiveness of IPE and general healthcare education if we did focus more on altruistic attributes in application processes. And I'm not familiar very much with the applications processes for different types of schools, but I have heard people talk about shifting the way that we identify and recruit and accept students to different health professions. And I think right now a lot of times it's thought to be your grades, if it's medical school, it's your MCAT scores, and it's not as much how good are you with people, how much do you like people, how much do you like working in a team, because there will be always plenty of people who intellectually can pass the classes and do those things. But I think to be able to actually work together and improve healthcare, we need people who actually want to work with people too.
Any other comments?
I agree with that as far as the application process. The U does a really good job as far as pharmacy school, in that they close off the application file on grades. They don't even look at grades until after the interview. The interview is actually based on supplemental questions that they've had on why you want to do pharmacy, on any examples of teamwork that you've had. And so they focus on those altruistic values that Erin was discussing about. And there is, the filter is not always the best. I have heard that there are some pharmacy students that just aren't people person. And that's fine, because in pharmacy, there are going to be people that would hide in the lab downstairs in the basement, and you just would never see them. But then there's also the other spectrum where there are students that are people persons that do like teamwork, and those are the people I would much rather focus on and build their strengths and build their value and potential that way, as opposed to looking at the overall gamut of all the pharmacy students and making sure we capture every single one of those students.
All right. So final question. Yes.
Thank you very much for your presentations. I think you struck on something that resonates for me. And that's the distinct differentiation between IPE as a tactic to get us together for learning experiences and interprofessional collaborative practice competencies, which is the goal of IPE. Sometimes we talk as if they're the same thing. What we want is the latter, not the former necessarily. Did you feel in your schools, because I heard it in all 4 of your presentations, the clarity of, at the end of the day, you wanted to be a competent in interprofessional collaborative practice. How do you think your schools describe that to you? Do you think it's clear? Because I know in some schools it's not. In some schools it's all about the event and being able to check the box that says, yes, we brought multiple groups of learners together at one point in time. How, did you see it explicitly, implicitly, or only when you experienced did you find this from your school?
I think that really largely depends on your specific experiences from a medical school standpoint. The curriculums kind of divide in terms of your 3rd and 4th year training in terms of how you're doing your rotations and your clerkships. So for me, I would say that my interprofessional learning continued. There was less formal interprofessional requirements and activities that we had to do. That has since kind of changed. Talking to Dr. Blue for a brief update on how things have changed. They are actually doing some required clerkship activities that are interprofessional, where you meet with a social worker, for example, or go over a patient care plan with a pharmacist and you kind of write a review or reflection of it. But I do think that those activities are, critical and they're important. And I think for me, though, it was just more of what I saw. So I saw when I did my psychiatry rotations how well the team worked together. I saw it on internal medicine when we had the pharmacist with us on rounds who made recommendations about an antibiotic. Those were like classic points, concrete examples of interprofessional practice, like you're saying. In terms of me feeling competent, though, and how my university officially prepared me for that, I would just say those were things that were in place that then I felt like I was prepared to participate.
Erin, do you have a question? A comment? No. Okay, the very last question.
Did your IPE activities help you just to work together in a team clinically? Or did it give you skills that you are also agents of change so that patient outcomes in the health system will improve? So, are you really a change agent, or are you just keeping the system going, but you're just working together because you've been shown how to work together?
I was talking to Dr. Blue before this conference, and we were talking about working together. And one of the things that I've said often about interprofessional education is that it's not just about being a good person. It's not just about being respectful of other professions. I think that there's a certain professional respect we should all experience for each other. It's about good patient care. So when we know how to work together, when we understand and respect each other's backgrounds, trainings, and expertise, the patient is who is at the focus and who can be saved. I kind of go back to the example I gave earlier in my talk when I had a patient on medicine that I needed to get placed into a skilled nursing facility, and I had to get a physical therapist involved. So I actually called the physical therapist when I called the consult, and we had a talk about it, and I told them specifically what I thought was going on with the patient and if they could follow up with me. There was a real open line of communication between the two of us, and they paged me after they went and saw the patient, and we talked about it and kind of went from there with the appropriate plan. I'm not saying that if you didn't have interprofessional education or training, you wouldn't do that. But it's just that that mindset was kind of set for me. I knew that that was something that could happen, and I had been shown in some of my examples in medical school that when teams work together, when there is that open line of communication, that you can produce good patient care. So I think it does help with patient care.
Aaron, I might hold you back. I think we're over time, I'm afraid. If you could interact afterwards in the break, that would be super. So just, yeah, thank all the panel and Angela. Thank you. Thank you for joining us, Angela.
I don't know about you, but one of my impressions is, excuse me, as a boomer, I am relieved to know what the next generation of clinicians is all about. And thank you again for your contribution today. The second thing I know is I feel like I've been drinking from a fire hose all day. And so the good news is that's about to change subtly. This workshop was informed profoundly by the breakout sessions from our August workshop, during which time we asked the participants to help us identify who some of the exemplars are so that we could in fact bring them to you in this second workshop. And so I want you to go into the breakouts that are about to take most of the rest of the afternoon with the same thought in mind, that the conversations that you're going to have, skillfully facilitated by leaders and recorded by recorders and staff, will influence the work of the forum going forward. You have, I think everybody has a copy, Patricia, of the breakout assignments that are not inclusive of all of you. The forum members were asked specifically if they had a preference of which workshop to go to. The other registrants, not so much. And so if you're not assigned to a group, but want to participate in the group, please know that you're absolutely welcomed, encouraged, and invited to do so. The group's description of what each one will be focusing on, what question you're being asked to discuss and to come back and report answers to are in your agenda. I won't repeat them. And on the breakout group assignments are the room assignments. 2 on this level, 1 on the 5th floor, and 1 on the 6th floor. I would ask you to do me also one other favor. When we come back here after a brief intermission at 4 o'clock to get back here to start promptly at 4:15, there is going to be a brief session where, rather than the reporters reporting out, which they'll do formally tomorrow morning, we're just going to give all of you an opportunity to share some ahas that came from the conversation. And it could be a very pregnant pause if you don't come back with some of those. I'm not worried. Most of you have been wanting to say something all day, but only a fraction of us have had the opportunity to do so. So please enjoy the conversation between now and 4 o'clock, and I look forward to seeing you back here at 4:15. Oh, I'm sorry. Let me announce the rooms then. Group 1 will be in room 101 on the main level, which is this room right here. Group 2 goes up to room 600 on the 6th floor. Group 3 is in room 100 on the main level. Also, oh, okay, this is group 3. Room 101 is over to the side, and then group 4 is in room 500 on the 5th floor.